agents. Okay, the remaining oral hypoglycemic agents. The insulin sensitizers. So we have mentioned about the sulfonylureas. Now today, let me take you through about the insulin sensitizer and other anti-diabetic medication shortly. Then after that, we shall discuss about the principle of management. When do we use monotherapy? When do we use combination therapy? Then towards the end, we are going to discuss about the acute and the chronic complications of DM and its principle of management. So the insulin sensitizers, like the biguanidase and thiazolidinediones, are very important. So mostly they lower the blood sugar level by improving the target cell response to insulin without increasing the pancreatic insulin secretion. So they don't have an effect on insulin secretion, but they're actually very important to like sensitize the action of insulin to the target organ. So let's see first metformin. Remember, metformin, if there is no contraindication and if it is tolerated, metformin is like the preferred initial pharmacological agent as the monotherapy as well as the combination therapy for almost all types, all type 2 diabetic patients. So I will not go in detail about the mechanism of action of metformin because I'm thinking you have discussed in the pharmacology session, but mostly it lowers the blood sugar level by decreasing hepatic glucose production, and it also increases insulin sensitivity in the target tissues. That is the principal, like despite the exact mechanism is not known, that is a plausible mechanism of action of metformin. Okay, then unlike sulfonylureas, metformin retains the ability to reduce the sugar level in case of glucose toxicities. So even when the sugar level is significantly high, in case of sugar toxicity, still it can actually retain to reduce the sugar level. Then apart from that, since metformin does not affect the release of insulin from the beta cells of the pancreas, the risk of hypoglycemia is not as such. So it is one of actually the euglycemic drugs. So it is very likely to have hypoglycemia with metformin treatment alone. Of course, if it combines with other medication like the sulfonylurea, there is a possibility. But otherwise, metformin alone is very likely to cause hypoglycemia. So hypoglycemia will not be an issue. Then apart from that, the patient usually lose weight because metformin normally like cause loss of appetite. And that is why it is actually a drug of choice in obese type 2 DM patient because it can actually lower your appetite and ultimately reduces the weight of an individual, which is very common in type 2 DM patient. Then apart from that, we have to be very cautious in when a patient is having renal problem and when they are on metformin treatment. It is very good to be very cautious. So especially if the eGFR is actually reduced between 30 to 40, we can use with dose adjustment, but most guidelines do not recommend the use of metformin in a renal patient because of the risk of lactic acidosis. I will come later why we need to be very cautious. So what is the most common dose of metformin? Remember, metformin is like the most widely used available, widely used medication in our setting even. So mostly we use like 500 milligrams twice daily, or we can use even the 850. The strictness we're having with like 500 tablet and 850 tablets. So for the 500, we can use twice daily, but 850 we can use once daily when we initiate. Then we can actually titrate until the maximum dose of metformin is like this much amount. But most physicians, they use normally like 2000 milligram, like 2 gram. 2 gram of metformin is the most commonly used doses. Okay, then As I mentioned before, when the AGFR is like between this level, it's good to actually limit the dose of a maximum of 100 milligrams. So what we fear with EGFR of metformin is, in fact, metformin is cleared by the renal system, but what we fear with metformin is actually the risk of lactic acidosis will be very high. Remember, metformin promotes the production of lactic acid production, because it actually promotes anaerobic metabolism of glucose. What will happen when a patient is taking metformin? Now, let me take you back to biochemistry for a few minutes. Remember, when there is a need of glucose, glycogen undergo breakdown, that is in the fasting state. Glycogen, then glucose. So what will happen? This glucose undergo glycolysis, then it produces pyruvate. So remember, when glucose undergo glycolysis and produces pyruvate, there is a generation of ATP. Then this pyruvate undergo metabolism by pyruvate dehydrogenase enzyme, and there is a production of what? Acetyl-CoA. So remember, this acetyl-CoA is the one which is important for the Krebs cycle. Like this is one of the component of the precursors of the Krebs cycle. So acetyl-CoA combined with the other metabolic products so that it can actually generate energy in the Krebs cycle, or that is electron transport chain. So when a patient is given metformin, what will happen? Metformin inhibits the pyruvate dehydrogenase enzyme. Then this pyruvate will not be converted to acetyl-CoA. Instead, pyruvate will be actually converted to lactic acid. So there is a generation of lactic acid. So that is why metformin increases the risk of lactic acidosis by inhibiting the aerobic mitochondrial oxidation. So aerobic oxidation of glucose will be inhibited because of its ability to inhibit this enzyme, and the risk of lactic acidosis will be very high. So specifically, when a patient is having underlying renal problem, like the clearance of acid from the kidney will be reduced, and this ultimately increases risk of lactic acidosis. Because of that reason, generally speaking, try to avoid the use of metformin if the AGFR is less than 30 ml per minute. But most of the guidelines, they don't recommend metformin even when the patient is having renal problem. So when you look at the side effects of metformin, most of the side effects of metformin are GI in nature, like decreased appetite, nausea, and diarrhea are very common, but mostly it can be minimized through slow titration of the dose, and often subsides within 2 weeks' time. So GI-related side effects of metformin are quite common, but you advise the patient properly, it will subside like within 2 weeks of treatment. Then apart from that, with long-term use of metformin, the probability of having vitamin B12 deficiency is very high, and ultimately the patient will end up having macrocytic anemia as a result of vitamin B12 deficiency. This is just because of interference with the absorption. As I mentioned before, because of its ability to inhibit mitochondrial oxidation, there is a possibility of actually like a chance of developing lactic acid accumulation. So this is all about metformin. The other class of insulin sensitizer is thiazolidinedione. So thiazolidinedione, I think they are available locally. Rosiglitazone and the pioglitazones are available locally. They are actually part of the insulin sensitizer. They increase insulin sensitivity to the target tissues. That is the principal mechanism. And we usually, this is the doses. Like I think pioglitazone is available locally, 15 to 30 milligrams per day. That is the dose recommended. And we can actually even increase up to 45. That is the maximum dose. But what we need to be very cautious with, as will be down, is the possibility of fluid retention and edema. So when a situation, like in a situation such as heart failure, like whereby fluid retention or increased fluid volume is detrimental, this class of drugs are contraindicated. So when a patient is actually having heart failure, along with DM, and this will not be a drug of choice because of fluid retention. And apart from that, thiazolidine class of drugs, they do have an ability to cause some kind of toxicity on the liver. So liver function test monitoring is very important. But they also cause, by the weight gain. This weight gain is most likely related to the fluid retention, but dyslipidemia is very common, but it is usually with rosiglitazone, like increased LDL with rosiglitazone is actually very common. So anyways, what we feel with thiazolidine is the fluid retention and edema in cardiovascular patients. Then the other class of drug is the alpha glucosidase inhibitor, like the carbos and miglytol. So the alpha glucosidase enzymes are the one which is important to break complex carbohydrates to monosaccharides so that it can be absorbed and utilized by the body system. So mostly the role of alpha glucosidase enzyme inhibitors, they are important to delay the absorption of carbohydrate and reduce postprandial glucose concentration. So the whole idea is just like to reduce postprandial glucose concentration by inhibiting the breakdown of carbohydrates. But the major problem with this class of drugs is hidden of GI side effects are very high. Because of that reason, they are not commonly used nowadays. The other class of drugs we are going to see is the DPP inhibitor. They are known as gliptins. I think some of them are available locally. Maybe you can actually check in the local chemist about the availability of those drugs. Mostly this class of drugs, remember, DPP enzyme is the one which is important for degradation of endogenous GLP-1, which is mostly released from the GIT. So GLP-1 is an endogenous incretin. So those incretins are the one that can actually increase the release of insulin as a result of like male-induced hyperglycemia. So when the glucose is actually very high after food intake, now the GLP-1 will be stimulated from the released from the GIT, then they indirectly stimulate release of insulin from the beta cells of the pancreas. So they do have indirect effect. Because of that reason, they are very important to lower the blood sugar level by after food. That is that's the main important action. They do have some side effects like headache and nasopharyngitis are actually the most common side effects. But remember, the possibility of hypoglycemia is not very common if we use the monotherapy because the effect on the insulin is like indirect. Like the release of insulin will be stimulated by DPP-4 inhibitor when the patient is taking food. Because of that reason, they don't have like any direct effect on the beta cells of the pancreas. So hypoglycemia is not a common effect. Then lastly, the sodium glucose co-transport 2 inhibitor. Remember, they do have a suffix of gliflozin, and I will talk something about dapagliflozin. So those are the newer anti-diabetic medication. I don't know really. Maybe is there anyone who checked in the local market, like which anti-diabetic medications are available? Did you manage to check? Anyone who can who managed to check those anti-diabetic medication? So it seems like no one tried. Okay, anyways, I'm not very sure about the availability, but I think this one might be available. If you can, maybe you check. So SGLT is a transporter in the kidney which is responsible for 90% of renal glucose reabsorption in the proximal renal tubule. So the SGLT2 inhibitors are proposed to inhibit this transporter. As a result, it actually promotes urinary excretion of glucose and ultimately lowering the blood glucose level. So remember, this class of drugs they are approved as an adjuvant therapy to diet and exercise to improve glycemic control in type 2 DM patient. But remember, this class of drugs, apart from like reducing the blood sugar level, they do have renal protective effect. They do have renal protective effect. How do they protect the renal system? Renal protective effect, they actually reduce proteinuria. They do have some effect on the renin, angiotensin, aldosterone system. And apart from that, they can actually even prevent the reabsorption of sodium from the proximal renal tubule, and they resolve some kind of edema in cardiovascular patients. So even recently, this one, the pagliflozin, you can actually go and check, is approved for treatment of heart failure. Anti-diabetic medication, but it has actually had some effect to reduce the incidence of like the progression of heart failure. And it is approved in May 2020 by FDA of the US. This is actually the newer addition of like drugs for heart failure management I have seen recently. So that means when a patient is actually having any cardiovascular condition with DM, this class of drugs will be the drug of choice because they are only protective. They are also actually reducing cardiovascular mortality. So if you are interested, you can actually read more. So what is the major adverse effect of SGLT2 inhibitor? Remember, they are actually increasing the concentration of glucose in the urinary tract. Because of that reason, they can actually increase the urinary tract infection. Remember, when you increase glucose in the urinary tract area, and glucose is actually like the base media for the growth of microorganisms, so UTI can actually even happen. And even like in the genital area, there is a possibility of candida infection. Remember, in the spring semester, we have discussed about like those normal commensals, like normal flora in the vaginal area is candida is actually the most common. It usually loves like a very moist and warm environment. So in the oral cavity in the genital area is the moist area which loves for the growth of, which is actually a good environment for the growth of candida species. So when you increase the glucose level, it is a good environment even for candida to grow and cause a super infection. So genital mycotic infections are also common as a result of SGLT2 inhibitor use and etc. Then the non-insulin injectable agents like glucagon, like peptide agonists. So mainly, they are actually injectable preparation. They are injectable anti-diabetic medication, and the principal role is to increase glucose-dependent insulin secretion. So they actually, when the glucose level is very low, they can actually promote the release of insulin indirect effect. So that is the most probable use of, and this is actually the dosing schedule of this class of drugs. I think you can read this part. Now, this non-insulin injectable agents or the glucagon-like peptides, they can actually increase risk of hypoglycemia when it is combined with sulfonylureas or insulin. If we combine them, of course, they do have overlapping effect. That means they promote the action of insulin, and ultimately the patient can have hypoglycemia. However, the main side effect of this class of drugs are nausea, vomiting, and diarrhea, vomiting and diarrhea. Okay, so this is all about the anti-diabetic medication we are going to use or in the management of type 2 DM. So having said this much, now let me take you through about the principle of management in type 2 DM. Firstly, when do we use insulin in type 2 DM? There is a scenario when we are going to use insulin type 2 DM. Remember, when the remaining beta cells function undergo or deterioration, now the patient becomes insulin dependent. That is why after long-term use of oral hypoglycemic patient, now we don't see significant response with the oral hypoglycemic agents despite we give combination therapy. In such a scenario, that is most likely the beta cells of the pancreas is no longer producing insulin, they become insulin dependent exogenously. Then that is one circumstance. The other circumstance we can use is when a patient is having severe hyperglycemia, it is very likely to achieve reducing the sugar level with oral hypoglycemic agents alone. This is when we are supposed to use insulin. Then in case of hyperglycemic emergencies, diabetic ketoacidosis, hyperosmolar hyperglycemic status, those are the most common types of hyperglycemic agents you can happen as a result of like glucose toxicities, which is very common in the practical setting. So in that condition, we don't use other oral hypoglycemic agents because they are not very efficient to reduce the sugar level immediately. Then other conditions in case of organ failure, in case of renal issues, like the renal system is the one which is most important to clear most of the oral hypoglycemic agents. So if they don't clear, then it can actually cause significant problem. And in case of pregnancy, we have mentioned insulin is the only drug which does not cross the placental barrier, so that we just use it doing insulin, despite there is like some kind of evidence on metformin use and glibenclamide, still it is not approved to use. So insulin is the only drug to manage gestational DM. Okay, then let's see the principle of glycemic management in type 2 DM. Remember, if there is no contraindication or any contraindication, metformin is the front line or the initial drug in the management of type 2 DM. Then, in terms of consideration of monotherapy and combination therapy, what guides you? The combination use of oral hypoglycemic agents is the level of glycated hemoglobin. So far, the current guideline of American Diabetic Association, so combination therapy and the use of what guides you, the use of combination therapy or monotherapy is the level of glycated hemoglobin. So if the glycated hemoglobin level is between 6.5 to 7.5, use either metformin is the preferred, but we can also use the DPP-4 inhibitor, GLP-1 agonists, and also even alpha glucosidase enzyme inhibitor. So if the glycated hemoglobin is between this level, monotherapy is sufficient to control the blood sugar level. That is the idea. Then, but however, before you consider changing or adding another medication, you have to try a minimum of 2 to 3 months with the initial agent before we add the other agents. That is the recommendation from the American Diabetic Association. Then, when the sugar glycated hemoglobin level is between 7.6 to 9%. Now, in this condition, dual therapy is important to control the sugar level appropriately. Then metformin will be part of the combination therapy. Still, metformin will be the backbone of combination therapy unless there is any contraindication. So metformin can be combined with a GLP-1, can be combined with DPP-4 inhibitor, can be combined even thiazolidinedione, even sulfonylureas and etc. So that is the recommendation. So remember, still we need to continue. Still we need to continue a duration of 2 to 3 months before considering additional agent. That is also another recommendation. Then now, when the glycemic level is above 9%, and if the patient is symptomatic, give insulin with or without any other oral agent. But if the glycated hemoglobin is above 9%, and if the patient is asymptomatic, maybe dual or triple therapy can be sufficient with a metformin at the backbone. So this is the principle of treatment in type 2 DM. So when the glycated hemoglobin is lower, use monotherapy. When it is high, consider combination therapy. When it is very high, that is when you are going to consider even triple combination therapy. Then what other circumstances? Let's see about other circumstances of managing type 2 DM. So when a patient is having any cardiovascular disease, or maybe a heart failure coexist, SGLT2 inhibitors are the preferred because they can reduce the progression of cardiovascular disease apart from controlling the blood sugar level. That is why this class of drugs are preferred. And I told you, one of the SGLT inhibitors are actually even approved for managing heart failure. So heart failure plus DM, this will be the preferred. Then secondly, when a patient is having type 2 DM plus CKD, SGLT2 inhibitor or GLP-1 agonists, they are shown to reduce the progression of the disease because they reduce what? They reduce proteinuria. I've already mentioned about those class of drugs are renoprotective. But remember, despite SGLT2 inhibitors or GLP-1 renoprotective, most of the guidelines recommend insulin will be the preferred treatment modalities when a patient is having CKD plus DM. Yes, but if we don't have maybe insulin, maybe we can use this consider. We can also consider this because they are renoprotective, but mostly insulin will be the preferred treatment modalities because most of the other medication, they are not commonly recommended when the patient is having kidney impairment. Then lastly, so this is the treatment algorithm of type 2 DM management. So initially, what is the front line in the management is lifestyle modification, like healthy eating, control our weight, do regular physical activity, then initiate with metformin monotherapy. Then if we are not able to control the sugar level within 2 to 3 months, now that is when you are going to consider combination therapy, metformin with sulfonylureas, thiazolidinedione, DPP-4 inhibitor, and etc., even with insulin. So depending on the glycated hemoglobin or the sugar level, we can actually consider combination therapy, 2, 3, or even insulin. Yeah, that is when we're actually giving, but insulin is usually given on that in the last resort because of the risk of hypoglycemia. Okay, so this is all about the principle of the management. And apart from that, even the ADE guideline is good to consider even all patients with a history of cardiovascular disease should be prescribed aspirin as a secondary prevention. That is very, very important because the risk of like atherosclerosis will be very high when the patient is having a hyperglycemia, like sugar causes like endothelial damage and causes increased risk of atherosclerosis and other cardiovascular condition. So because of that reason, regardless of the status of the cardiovascular condition, ADA recommends use antiplatelet therapy, aspirin 75. Then dyslipidemia. The statin therapy should be considered when a patient is having DM and no history of clinical atherosclerotic cardiovascular disease between the age of 40 to 75. Yeah, that is a recommendation with LDL level between this is generally recommended. Remember, in type 2 DM, dyslipidemia is also very common. So statin should also be considered. But like the current evidence showed that statins has no benefit when the patient age is above 75. Rather, the risk outweighs the benefit. Can you do more search why statins are not benefit after the age of 75 years? So generally speaking, after the age of 75 years, statins are not usually recommended. Then what do we do if they do have hypertension? If they do have hypertension, it is good to control the BP adequately, and the drug of choice will be ACE inhibitors and ARBs. I mentioned this one, ACE inhibitors and ARBs are renal protective to prevent the progression of the disease. This will be the drug of choice even in DM plus hypertensive patients. Then what about if the patient is having HIV with DM? So remember, there is a possibility of glucose disturbance, like homeostasis glucose will be happen with the protease enzyme inhibitor. Remember, protease inhibitor, they can cause increase the level of triglycerides, or they can cause dyslipidemia, and they can cause even hyperglycemia. Because of that reason, when a patient is having DM with HIV infection, try to avoid any protease enzyme inhibitor. I think that is like the whole message of this slide. So avoid protease inhibitor because it can actually even cause insulin resistance. Then when a patient is actually taking metformin, try to avoid in combination with other nucleoside reverse transcriptase inhibitor, such as stavudine, sidovudine, and idanosine. But this stavudine is no longer in the market because of its cosmetic effect, like it can cause hypertrophy. It can actually even cause like loss of subcutaneous tissues in the cheeks, and it has actually cosmetic effect. Because of that, it's no longer in the market. But the sidovudine is still in the market, like even in the prevention of mother-to-child HIV transmission. Apart from nevirapine, sidovudine is also used. It's available as second line. Idanosine I've never seen, but anyways, this class of antiretroviral drugs, they can increase the risk of lactic acidosis. If you combine with metformin, the risk will be actually even higher. So because of that reason, avoid any antiretroviral with metformin along with those antiretroviral medication. I think that is the whole message. Then apart from that, when a patient is actually having mental disorder, maybe psychiatric disorder with DM, we need to very cautious about when you are choosing antipsychotic. Specifically, there is an association between second generation antipsychotic and development of DM. We shall discuss next semester in detail about the association, but for the time being, some of the second generation antipsychotics such as clozapine and olanzapine are very notorious to cause weight gain and ultimately insulin resistance, and even leads to type 2 DM. So because of that reason, but from second generation antipsychotic, olanzapine is the most widely used antipsychotic medication in Kenya. If you go to maybe in Matari, most like around 75% of the patients of schizophrenia or any other psychiatric disorder, they're actually on olanzapine, depending on availability. So remember, olanzapine or second generation psychotic, in general, they increase appetite. They actually they increase your appetite and you will eat too much and ultimately causes weight gain. But that is the only way, that is the only known mechanism how second generation psychotic causes weight gain. There are several mechanisms, but the most well-known mechanisms are by stimulating appetite. So what will happen? So remember, when a patient is having DM, will olanzapine will be a drug of choice to manage that psychiatric condition? It should not be, because olanzapine is the most notorious to cause weight gain from all antipsychotic medication. So because of that reason, when a patient is having DM or maybe high risk, like very obese, avoid or switch a drug that is actually having lower effect to cause weight gain, maybe risperidone or any other classes, but those two are the most notorious. So this is all about the principle and management of DM with concurrent condition. Now, in the next few minutes, I'm going to take you through about how do we manage acute complications of DM, such as hypoglycemia, ketoacidosis, and hyperosmolar hyperglycemic state. So hypoglycemia is mostly associated with inadequate, like high dose of use of like high dose of insulin. So it is associated with insulin therapy. Are we together, by the way? I may be a bit fast, but I have to finish like this part today. So are we together? Or maybe some of you are doing other things.
We're together.
Okay, fine. Hypoglycemia is mostly associated with insulin therapy, but diabetic ketoacidosis is one of the most common complications in type 1 DM. But hyperosmolar hyperglycemic state is mainly associated with type 2 DM. And we will see how we are managing those conditions, what are the difference between the diabetic ketoacidosis and hyperosmolar hyperglycemic status. So hypoglycemia is defined as when the sugar level is like less than 70 milligram per deciliter. So what causes hypoglycemia? Mostly delayed intake of food, especially carbohydrates. And also it could be like excessive dose of anti-diabetic medication, mainly those high risk of hypoglycemia, such as sulfonylureas and insulin. Or it could be even due to like doing exercising, like heavy exercise when the insulin dose are reaching peak effect. Okay, so those are the most common causes of hypoglycemia in diabetic patients. So how do they present? They tremor. When a patient is having hypoglycemia, they tremor, they sweat, they become very fatigued, headache, confusion, and even ultimately coma, and this can happen if immediate intervention is not dependent. If immediate intervention is not done, there is a possibility of death. So how do we treat hypoglycemia? The treatment is very simple. You give them a glucose tablet or maybe give them a soda. Can be even sweet, it can be any other that contain actually sugar. But if the patient is actually unconscious, there is a need of glucagon administration. Remember, glucagon is the one that glucagon is one of the most common counter-regulatory hormone that can actually even counteract hypoglycemia. Yes, so glucagon subcutaneously can be given IM or subcutaneous 1 milligram. It can be repeated 50 minutes as needed. In 50 minutes as needed, it can be repeated. So like for hypoglycemia, the treatment is simple. You give them a glucose tablet if the patient is unconscious. But if the patient is conscious, if the patient is unconscious, you give them glucagon subcutaneously intramuscularly. So let's see about another acute complications of the DM is diabetic ketoacidosis. Remember, this diabetic ketoacidosis is one of reversible but potentially life-threatening medical emergency that usually happen as a result of absolute insulin deficiency. So without insulin, by the way, I mentioned at the beginning of DM, without insulin, the body cannot utilize glucose as a source of energy. Then as a result, now the lipid undergo degradation. Then as a result of lipid degradation, now there's ketone body formation and that leads to acidosis. So what causes acidosis is the lipolysis as a result of starvation of the cell. So it is very common in type 1 DM patient, and it can be precipitated by infection, maybe omission or inadequate administration of insulin. Those are the principal cause of diabetic ketoacidosis. So what are the principal symptoms when a patient is having DKA? So it occurs rapidly over few hours. The patient can have fruity or acetone breath. There is a possibility of having nausea, vomiting, dehydration, and etc. There is also polydipsia, polyuria, deep and rapid breathing. It's just like the deep and rapid breathing is actually to remove excess amount of acid in the form of carbon dioxide. So that is the compensatory mechanism. So remember, what kills the patient in DKA is the dehydration. So as a result of the osmotic effect of glucose, there is a possibility of having intracellular dehydration. Let's say this is the intravascular compartment. So this is the interstitial space, and this is the cells. Okay, so this is the interstitial space. This is the intravascular compartment. Extracellular fluid, maybe this one intracellular fluid. Like the plasma interstitial space is extracellular fluid and the cell is intracellular fluid, ICF. So now, when a patient glucose level is high, like in the plasma, when the glucose level is high in the plasma, now what will happen, the direction of the water flow? It could be from the cell to the plasma. So this allows, or this ultimately causes what? Cellular dehydration, intracellular dehydration, and ultimately lysis of the cell will be very high. So because of its osmotic effect, it draws water from the cell to the plasma and ultimately causes polyuria. So because of that, the patient can have dehydration. But remember, when there is a water shift from the cell to the extracellular environment, there is dilution of sodium. So this ultimately causes hyponatremia or low level of sodium. So in case of DKA, low level of sodium is a common finding. Then apart from that, because of its osmotic effect, it can also even promote the removal of sodium from the kidney. So that means it can actually prevent the reabsorption of sodium. So hyponatremia is also another common finding in DKA. Then apart from that, because of the osmotic effect of glucose, it can also inhibit the absorption of other electrolytes such as potassium. So potassium deficit is also very common. Then apart from that, as a result of dehydration, the renin, angiotensin, aldosterone system is significantly activated. So when the RAS system is activated, now it can even lower the potassium level. So because of those two reasons, low sodium level and low potassium level is a common finding when a patient is having diabetic ketoacidosis. So, what are the hallmark in the diagnosis of DKA? There are three triads of DKA. One is hyperglycemia, the other one is ketosis, and the third one is acidosis. So those are the three triads. So when a patient is actually having those conditions at once, we can say the patient is having diabetic ketoacidosis. So the sugar level should be actually above 250, and the ketone bodies in the serum high, and the pH is actually less than 7.3. So how do we manage DKA? Management is usually reversing the underlying metabolic abnormalities, and we rehydrate the patient and normalize the glucose level. But this one is the first priority. Remember, what kills the patient is dehydration as a result of like sudden shutdown of the renal system. When the patient is having dehydration, now there is actually like complete shutdown, acute renal failure. So when the kidney is completely shut down, now the those metabolic wastes such as creatinine will be elevated and causes even uremic encephalopathy. Ultimately, the patient will end up having brain damage as a result of AKI. Then, how do we manage? Remember, in managing diabetic ketoacidosis, the first thing that comes to your mind is you have to very sure whether the patient is having DKA or not. That means, how do you know? Look at sugar, ketone, and arterial blood gases. That is very important. Then you are admitted to the hospital. Intensive care setting may be necessary for frequent monitoring, or if a pH is actually very low, like less than 7, or if the patient is unconscious. Then assess the electrolyte level, because the potassium and sodium electrolyte imbalance and the acid-base disturbance is very common. Of course, we need to look at even the renal function. Because of dehydration, the patient renal function can be low. The urine output can be low, and the creatinine level can be low because of AKI secondary to dehydration. Then secondly, after that, replace fluid. That is very important. So to restore the vital sign. Remember, as a result of dehydration, the patient will end up having days due to cardiogenic shock. So what you can do is replace the fluid as soon as possible. How much amount of fluid? Normal saline, mostly 15 to 20 ml per kg per hour. That is the recommendation. So the first thing that should come to, or the first priority of treatment in DKA is replace fluid as soon as possible with this much amount. That is the first thing. Then after that, once the intravascular volume is restored, the next step is give hypotonic saline. By the way, there are two things you have to know. If you give them isotonic saline alone, the patient can develop even hypernatremia, as well as even hyperchloremia-induced acidosis can happen. So that is why you are going to use like booze. If you use hypotonic saline alone, the patient can develop even cerebral edema. So because of that reason, you actually use both body fluids in managing DKA, depending on the level of sodium level. If the sodium level is maybe normal or high, we can use hypotonic saline. If the sodium level is actually like low, we can use normal saline. But generally, you give initially normal saline, but after that, when intravascular volume is restored, now you can actually consider hypotonic saline with this much amount. But if the corrected sodium level is reduced, we still continue isotonic saline. Then after that, when the sugar level is reaching to around 200 milligram per deciliter, Now this is when we are going to add dextrose. So why dextrose is added? Why dextrose is actually added? This is just to prevent the possibility of hypoglycemia, because later on, after we restore the intravascular volume, we are going to give insulin infusion. So we have to add glucose in the fluid. Then replace potassium deficit. Remember, regardless of the initial measures of potassium, patients with DK have a large total body deficit, as I mentioned before. So if the potassium level is less than this, hold insulin therapy. Because even insulin promotes what? Insulin promotes what even? Hypokalemia, because in insulin activates the sodium potassium ATPase, which pumps like sodium out, potassium in. So when you give insulin, like this one will be activated more. So it pumps like more of the potassium into the cell. So it can actually even worsen the condition. Okay, fine. So that is one condition. Then if the potassium level is between these, you give just a small amount of potassium chloride with IV fluid. If potassium above 5.3, don't give potassium supplement, but you monitor every 2 hours. Huh? That is the recommendation. Then now, this is the time we are going to consider insulin therapy. So all patients without having low potassium level, they're supposed to be given regular insulin. So there are two types of regimen we can give. Either bolus, then continuous infusion, or you just give them continuous infusion of 0.14 units per kg per hour. You can give them either 0.1 bolus, unit per kg bolus, then continuous infusion of the same per hour until the patient, the acidotic condition is actually resolved. But remember, don't give insulin if the potassium level is below 3.3 milliequivalent per liter. So, but you have to replace potassium and fluid deficit first. Those are very urgent. Replace potassium and fluid deficit first before you give insulin. That is the recommendation. Then, if the glucose does not fall below like 50 to 70 milligram per deciliter, in the first hour, what you can do is you can actually double the dose, the rate of infusion. You can double the rate of infusion. When the serum glucose level reaches to like 200, now you can decrease the rate of infusion of insulin, and you continue until the ketoacidosis is resolved. And later, when the ketoacidosis is resolved, now you can start subcutaneous insulin administration. Then, now this patient, they also have acidosis. So, in case of mild condition, like when the pH level is above 6.9, don't give bicarbonate therapy. Why? Because the insulin therapy alone will resolve the acidosis. However, if the pH is actually below 6.9, you are supposed to give sodium bicarbonate. Maybe you can be even repeated if the pH remains below 7 after the initial administration. So if it is below, you have to give like 100 milliequivalent of sodium bicarbonate. So in summary, this is the treatment algorithms of diabetic ketoacidosis. So the first thing what comes to your mind is give IV fluid initially to restore the vital sign. Then look at the potassium level, then correct it accordingly. Then after that, I think the rest procedure, we have actually even seen it. Look at then after that, maybe you have to like give hypotonic saline depending on the level of the sodium level. Then you give insulin and consider bicarbonate if the pH level is less than 6.9. So you continue until you continue the treatment until the DKA condition is resolved. So generally, this is the brief treatment algorithms of diabetic ketoacidosis. Any questions so far? So are you in a position to give us a description of the DKA management? So who can give us the summary of the DKA management? How do you manage DKA? Maybe Faith, can you try? Faith, can you try, or you're not available? Okay, Vivian.
You start with fluids to deal with the hydration, and then you also you give the hypotonic fluid if the sodium is low. You also check potassium, and then if you avoid giving insulin with potassium because it can further exacerbate the potassium issues. You also check for what else was that? So that's what I can remember.
Okay, is there anyone who can support her? When are you going to give like the hypotonic saline when the sodium level is low? We can actually even exacerbate the condition. When the sodium level is low, we have to continue with normal saline. Yeah, that is the most common recommendation. But 15 to 20 ml per kg is the first fluid we're supposed to give, like with the first hours of admission. In the first hours, we have to give that amount of fluid, then we continue. Okay, any other who can support her? Anyone who can support her? Joan Muriki?
Maybe you can give bicarbonate, and the pH is less than 6.9.
Okay, fine. So consider bicarbonate if the pH is less than 6.9. Yes. Okay, fine. So what comes to your mind? Fluid should come first. Fluid and potassium assessment is the first thing, the first priority in the management. Then after that, you consider insulin. Then depending on the response, we can adjust, increase the dose. Then when the glucose level is actually less than like 200, we can reduce the rate of infusion, then continue until the DKA resolved. So when the patient is able to, like conscious and restore, like when the patient condition is restored, that is when you are going to consider subcutaneous route of administration of insulin. Okay, good. So this is all about the diabetic ketoacidosis. And please don't forget about the DKA management. Yeah, those are the most frequently asked question, like even in the board exam. I think I have seen like few questions in the essay part about the DKA management. Okay, fine, because it is very common, like one of the most common complications of type 1 DM. Then the next one, acute complication, is hyperosmolar hyperglycemic state. So now you have to, like at this point, after like at the end of this hyperosmolar hyperglycemic state, you should be able to in a position to differentiate between hyperosmolar hyperglycemic status and Okay, between HHS and DKA. So, hyperosmolar hyperglycemic state. It is a life-threatening condition that is similar to DKA that also arises from inadequate insulin. But it is very common in type 2 DM. But the difference between HHS and DKA is there is no lipolysis, ketonemia, and acidosis, which is commonly associated with DKA. So there is no lipolysis here, but it's only like the osmolarity of the serum is very high, and there is actually high sugar level. So no lipolysis, no, or in short, there is no acidosis and ketonemia. So so what are the diagnostic criteria for HHAS? The glucose level should be above 600 and the serum osmolarity is usually greater than 320 milliosmol per kg. So in this condition, if the osmolarity of the serum is very high, the glucose level is actually very high. As a result, the patient will suffer from severe dehydration because of the osmotic effect of glucose. Okay, fine, but there is no acidosis. So similar to DKA, the principle of management is the same. So treatment consists of aggressive rehydration, correct electrolyte imbalances, then give continuous infusion. So remember, because of extreme hyperglycemia and large fluid deficit, which results from osmotic diuresis, this is actually a major challenging to overcome this condition. So the principle of management of by the HHAs and DKA is the same, except the component of bicarbonate is not available here because there is no acidosis. So the first thing what you can do is confirm the diagnosis and replace the fluid and assessing the fluid status. So severe hypovolemia, give normal saline. Mild hypovolemia then you can actually even evaluate the serum sodium level. If high, you give hypotonic. If normal, you can actually even give hypotonic. If low, you better give a normal saline. Then when the glucose level reaches to like 300, you can actually change to 5% dextrose with hypotonic saline to prevent the risk of hypoglycemia as a result of continued insulin infusion. Still, we are going to use the soluble insulin, 0.1 unit per kg per body weight as IV bolus. Then 0.1 units per kg per hour continuous infusion can be considered. If no improvement, maybe we can actually double the dose. When the glucose level reaches to 300, now we can reduce the rate of infusion, and continue the treatment until the patient is actually stable. Then there is also component of potassium. If the potassium level is less than 3.3, you have to hold insulin therapy because insulin can cause arrhythmia. Hypokalemia can cause arrhythmia. So close monitoring of the potassium level every 2 hours is very important as we give the insulin infusion. So you have to hold. Between this one and this one, we can actually give 20 to 30 milliequivalent in each liter of IV fluid to keep the serum sodium between 4 to 5. If above 5.3, we don't give any potassium because it can increase, but we need to monitor every 2 hours. So the front line in HHS management is fluid, insulin therapy, and potassium replacement. So that is all about the management of acute complications of what? The DKA and HHS. Okay. Just give me 1 minute. I will be back shortly. Okay, fine. I'm back. Let me take you through about the long-term complications of DM. So one of the long-term complications of DM is diabetic retinopathy. Remember, diabetic retinopathy occurs when the macrovascular, the microvasculature that supplies blood to the retina becomes damaged. What causes that damage is the sugar because of this osmotic damage. So this ultimately causes blindness. So how do we prevent or how do we treat these long-term complications? Most importantly is control the glucose and the BP level. Remember, high blood pressure level can actually even cause damage of the retina and causes loss of vision. So control the sugar and control the BP will be the best strategy to slow down the progression of retinopathy. Then neuropathy is very common. Remember, as a result of high blood sugar level can cause damage of the peripheral nerves, even including sensory nerves. So there is a possibility of pain, tingling, numbness in the feet and hands as a result of peripheral neuropathy, and mostly nauseating, pregabalin and amitriptyline are the most commonly used drugs in the management of neuropathy in DM patients. We give pregabalin, then 150 or 300, depending on like the patient condition. We also give amitriptyline is an antidepressant, but it can be used in the management of neuropathic pain. So amitriptyline, usually 25 milligram, is given at night time because it causes drowsiness. Amitriptyline can cause drowsiness and it should be given at night time. So those are the two medications which is commonly given to manage neuropathy in the patient. Then secondly, thirdly, this one is the third one. How do we manage nephropathy? How do we manage nephropathy? So DM is the leading contributor to end-stage renal disease. It is actually the leading contributor of end-stage renal disease. So adequate management of the sugar is actually very important. So how do we manage still glycemic control and BP controls are the primary measures of prevention. So what will be the drug of choice still for controlling BP? ACE inhibitors and ARBs will be the primary choice because they are renoprotective. For glycemic control, we can use what? We can use SGLT2 inhibitor will be the drug of choice. Then the long-term complications, another long-term complication is actually diabetic foot ulcer. Remember, when a patient is actually having uncontrolled sugar, then it can actually causes damage of like the peripheral blood vessels. So like when someone is actually having trauma, they don't even notice whether there is a trauma because of the damage of the sensory neuron. Then apart from that, this one actually causes like causes damage, and there is actually a form of wound. Then apart from that, as a result of reduced blood flow, the immune system is usually reduced to fight infection in the wound areas because of the damage. So as a result, this diabetic wound ulcer is really a very, very common condition in diabetic patients because like as a result of decreased blood supply, the oxygen nutrients will be deprived and the immune systems are not able to function adequately, and there is a prolonged and ill ulcers, and ultimately there is actually a possibility of infection. Because of that reason, the patient will have actually having that problem. And so in managing this condition, what you can do is debriding the dead tissue will be the front line in the management of diabetic foot ulcer in the patient. You just clean remove any dead tissues, and apply any dressing material such as any antiseptics can be considered. Then, apart from that, we can actually even have adequate sugar control will also be another strategies. But apart from that, sometimes you have to use antibiotics in managing the infection. So what kind of antimicrobial agents can we consider when a patient is having this condition? Will be mostly anaerobic microorganisms, any agents or any antimicrobial agents that have an activity to kill anaerobic microorganisms such as the clindamycin and the metronidazole will be the drug of choice in managing like deep ulcer wound infection. But of course, when it is superficial, we can use even the anti-staphylococcal penicillin, such as cloxacillin. Cloxacillin can also be considered in managing this condition. Then apart from that, we need to advise all the diabetic patients to should wear properly fitted footwear and padded socks so that they will not so that they can actually protect themselves from having a wound, because that diabetic wound will take a longer time to heal because of the immune system is actually impaired as a result of reduced supply of blood to the extremities. So this is all what I have about DM in short. So if you do have any question, you are welcome.